Hi, my name is Dr. Jose Daniel Eugenio. I'm an endometriosis specialist. I did graduate residency in 2011 as a general OBGYN in New York. After that, I did fellowship in minimally invasive gynecology surgery and also endometriosis surgery, where I met the team at the Center of Endometriosis Care under Dr. Ken Sinervo. After that, I became an attending at St. Louis University and ultimately became the director of the Center for Endometriosis there before returning back to Atlanta, Georgia and joining the team at the Center of Endometriosis Care in Atlanta. Endometriosis is a disease in which endometrioid-like tissue, not similar, but not the same, but similar, grows outside of the uterus. We Latinos call the uterus the matrix. The matrix, right? Uterus or matrix. So the inside lining of the uterus is called endo, inside metrium matrix. The muscle of the uterus is called myo, muscle, and metrium matrix. So myometrium is the muscle of the uterus. Endometrium is the inner lining or the wallpaper of the internal uterine cavity. So endometriosis is a disease in which the tissue that is very similar to the endometrium grows outside. Why is this important? Because that tissue can have estrogen and progesterone receptors. There are the receptors that are responsible for stimulating the growth or stopping the growth, halting the growth of the endometriosis itself. So the most important thing about the symptoms of endometriosis is that they can be extremely varied. That's why you need to have a very focused exam on the patient, asking questions about painful bowel movements, painful urination, pain with deep penetration, pain with periods. When does the pain start? At the start of the period, days before the period, or after the period, and kind of having a general overview of all the symptoms that the patient is having before you can actually make a clinical determination if she's at increased risk of endometriosis. Once you make this determination, then you are able to use different type of testing modalities, sonograms with rectal prep, MRIs with both vaginal and rectal gel, plus different modalities in which you can evaluate the pelvic floor, the pelvic nerves, the obturator nerve, the pudendal nerve, and do very detailed pelvic exams that could give you a bigger understanding of what's the reason for the patient and her pelvic pain. So regarding endometriosis research, one of the things that's happening now, we're identifying a lot more genes that are involved in endometriosis, and I think this is where things are going to be moving forward in the future. We can basically do evaluations of a patient's gene and understand what is the risk or likelihood that she may or may not have endometriosis in the future. There are different studies in which they're doing different types of dyes so that we can inject it into the patient and then be able to see more detailed disease early on, which is particularly going to be very beneficial when we evaluate teen patients. There's so many misconceptions about endometriosis that would be almost impossible to like enumerate right now. One of the things that comes to mind really quickly is that a lot of our patients are usually told, oh, if you have endometriosis, that's not a big deal, get pregnant and it's going to go away. That is the most ridiculous statement that you can tell the patient with endometriosis, because they have to understand that endometriosis does not go away with birth control, with medication, with a GnRH agonist or antagonist. It doesn't go away with pregnancy. These are medical treatments that are meant to palliate the disease, meaning put it to sleep, slow it down, diminish the inflammation that the disease causes, but it makes you a slave to these medications, because once you stop the medication, the disease continues from right where it left off. Well, the reason I focused on endometriosis surgery is because after graduating as a general OBGYN and working in an academic institution, I realized that we as general OBGYNs, we're not really taught how to properly treat patients with endometriosis, because it's a surgical field. Medications, as I said before, may alleviate some of the symptoms, but they do not cure the disease. So surgery, proper excision surgery, gives you the best long-term outcome in treating the disease long-term. So the number one piece of advice is that there's a lot of different institutions. We've been listening to patients, and when patients complain and they make their voices heard, good things happen. Like this particular center, in which patients that may not have access to come to the US or may not have access to get proper care in their respective countries in Central South America, they can come to a center like this one and get proper care with endometriosis, where it's kind of like a one-stop shop, where they have endometriosis mapping, they have access to world-renowned surgeons, that are focusing 100% on endometriosis.